a lot of times when patients are counseled regarding general anesthesia, they have no idea that we end up intubating them. They have no idea that we have to ventilate them artificially and that they are paralyzed during the procedure.
Hi guys, and today we have a very special guest, Dr. Arjun, an MD in anesthesiology from KMC Manipal. Thank you for joining.
Thank you, Shivam. Again, it's a pleasure to be a part of your videos.
And today we will have few general questions discussed with Dr. Arjun. So firstly, how do you examine or prepare a patient for anesthetic?
So, anesthesia starts from your PACs, which we call as a pre-anesthetic checkup, where you take the history of the patient, both related to the surgical procedure which they're about to undergo, and also certain specific questions that you ask them related to anesthesia. So, this, whatever I'm saying, it's not to enable you to do PACs, but more of to sort of get you acquainted with what exactly we do. So I'll not be going into too many of the details. I'll just try to brush the basics of what we do. So you examine the patient, you do a basic vital checkup, you do a basic systemic examination, general examination along with systemic examination. Also, you have to do certain examinations which are specific to anesthesia, like you have to do an airway examination again, which you're not really trained to do in undergraduation or your internship. So that's something which is specific to anesthesia that you have to do. You basically have to find out whether the sort of anesthesia you'll be giving will be safe to the patient, what will be the best plan of anesthesia that you can give to the patient, and what are the other things that you can do during your anesthesia to the patient which will help them. And also, you have to find out whether there's any condition in the patient which will make it unsafe for you to give them a particular kind of anesthesia or any particular kind of medication or drugs during the procedure. So that is the basic idea of a pre-anesthetic evaluation, and then we go ahead with pre-medicating our patient, counseling our patient, and that's how we prepare a patient for surgery, essentially.
Okay, and what are the side effects of it?
So anesthesia has progressed a lot in the last 10 to 20 years. 20 years ago, we were using inhalation agents which would cause a lot of adverse effects. Modern day, the anesthetics that we use, most of them do not cause any long-term complications, and most of them wash out of the body in simple terms very fast. So most of them are daycare drugs. So you can give a patient anesthesia, by night time they could be happily walking around the ward. So that's why we say anesthesia has evolved a lot, and our modern anesthetics are not just safe; they're very acceptable to patients because they get eliminated from the body very fast. Of course, saying all that, there are side effects to everything that we give. There are situations where we have to avoid using certain inhalation agents, certain IV anesthetics, certain muscle relaxants. There are conditions in which some of these agents are preferred over others. So to know that, you have to know the pharmacokinetic and pharmacodynamic details of all of these drugs. But in general, I would say modern anesthetic techniques and modern anesthetic agents are much, much safer than they used to be before, and they're going to keep getting safer in the future.
So how will the anesthesiologist be monitoring the patient while he's under anesthesia? What are the most effective techniques for administering anesthetic or sedatives during a medical procedure?
So usually intraoperatively, we will be putting our basic ASA monitors where we will be monitoring their pulse oximetry or the saturation intraoperatively. We will be monitoring their blood pressure, which can be done either non-invasively using a blood pressure cuff in intervals of usually 5 minutes, or we can monitor it invasively when we need a beat-to-beat monitoring of their blood pressure. We will also be monitoring their heart rate via ECG leads. We will be also monitoring our inhalation agents, where we essentially try to find out how much of the agent is present in the lungs, how much of it is present in the blood, and how much of it is coming out via the endotracheal tube into the atmosphere. We also monitor things like our end-tidal carbon dioxide and our minimal anesthetic concentration, that is the minimal alveolar concentration, that is the MAC, intraoperatively. These are some of the basic things that are monitored for every case. There are more advanced monitors that we're using in our modern day practice day to day, and of course the amount and level of monitoring that we need to do depends on the case, and also depends on how sick the patient is, and will also depend on how invasive or how prolonged the surgery is.
Okay, and when does the anesthesia wear off?
That again depends. So usually there are two things that have to wear off. One is the muscle relaxation that you're giving. This is of course in case of general anesthesia. So the muscle relaxation that we give, uh, we usually reverse it with the help of neostigmine. So that has to wear off. The patients have to gain adequate strength of their muscles, and also the patients essentially have to wake up from sleep, which means that the inhalational agents which are in their blood have to come back from their blood into the alveoli and get washed out to the atmosphere. So usually we'll be cutting off the agents a little, maybe 3 to 4 minutes before the last suture, and approximately takes maybe 5 to 15 minutes for patients to wake up. Again, depends on the patient, depends on the surgery. Every patient will respond to anesthetics differently, but on an average, usually 5 to 15 minutes after we cut off the agents will the patient open their eyes, and that's when we end up extubating a patient from general anesthesia. When it comes to spinal anesthesia, depends again on the dose of spinal anesthesia that we use, but usually 3 to 4 hours after our dose of spinal anesthesia, the patient starts recovering motor power of their lower limbs.
Okay, and what risks should the patient be aware of?
So, a lot of times when patients are counseled regarding general anesthesia, they have no idea that we end up intubating them. They have no idea that we have to ventilate them artificially and that they are paralyzed during the procedure. So, that's something which patients have to be aware of, the fact that we have to ventilate them, because essentially when we give them muscle relaxants, they can't breathe on their own. So, we have to maintain their respiratory and cardiovascular system when we paralyze them. The only way we can do that usually is to either put a laryngeal mask airway or to put an endotracheal tube into the trachea and ventilate them artificially. This intubation itself can lead to a lot of complications. So that is of course a part of your pre-operative counseling, and it's a part of the anesthetist to go and explain to the patient what exactly we'll be doing, and also to make them aware of the possibility of complications that do arise. So when they do arise, you are medically legally covered because you told them that the possibility of this is there, but at the same time your counseling has to be proper in the sense that you do not scare patients and you tell them that there is a risk of cardiac arrest. Like if you tell someone that they might die during a lipoma excision, no one's going to want to get the lipoma excised. So this counseling again is very important, and it is an art and it takes time to practice, but it's a very important part of what we do.
Okay, and what should the patient expect after the procedure?
So usually you will be fully awake good 2 to 3 hours after the procedure, unless you are given a lot of opioids. Again, different patients respond differently to anesthetics. Some of them will wake up within good 30-45 minutes. Some of them will take longer. Some of them will still be quite drowsy 2 to 3 hours post-operatively. So it again depends and varies from patient to patient.
Okay. And after general anesthesia for a surgery, like how do you determine that a patient can be sent home?
We actually have a lot of criteria which look at the breathing, which look at the saturation, which look at the blood pressure, which look at whether the patient is able to move all their limbs adequately. We have different scoring systems, and we essentially determine whether it is time for the patient to leave the post-operative ICU and go to the ward, as to when the patient has to be discharged and when the patient is recovered enough to be able to be discharged home. That is usually the decision which is taken by the surgeons, but yes, the anesthetist can also play an active role in this discussion and participation. But usually we follow certified scoring scales, at least in our institute, to determine whether the patient can be shifted from the post-operative ICU.
And what do you do when your patient is nervous about their upcoming surgery?
Counseling is the most important thing. So like I said, counseling can be very distressing. If you go and tell your patient that they might suffer a cardiac arrest on table, that's just going to make them even more nervous. But at the same time, if you do not explain to them the risks of anesthesia, there are medical legal issues with that, because when something goes wrong, you have to explain to the patient that there is a possibility of things going wrong. So this is again a skill which takes time to learn, but it's a skill which has to be used very carefully as well. You should not over counsel a patient, and at the same time you should not under counsel them. So this is again a very important part of our job, and counseling, they say, is better than any kind of sedation or pre-medication, but oftentimes we will need to give the patient some kind of sedation or anxiolytic pre-operatively, but make sure we monitor them when we do it.
Okay, so I'll put an end to this video, and it was again a wonderful interview with Dr. Arjun. Thank you.
Thank you, Shivam. It was great to be a part of this experience.